right. Hello, everyone, and thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we begin, I would like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for upcoming LHS events, the next seminar will be on April 2nd by Dr. Suzanne Bakken of Columbia University. If you are in the Twin Cities area, the Department of Surgery and CLHSS are hosting Dr. Ho-Fung Poon from Microsoft Health Futures on campus March 18th and 19th. I will post more information in the chat. And with that, I will turn it over to Dr. Tim Beebe to introduce our speaker.
Hello, everybody. Thanks, Stephanie. Welcome to today's seminar. For those who don't know me, I'm the Deputy Director of our Center for Learning Health System Sciences. It is my distinct honor to introduce Dr. Tom Houston. Dr. Houston joined the Wake Forest Department of Internal Medicine in 2019. He is a professor in internal medicine and the Vice Chair for Learning Health Systems. So he's abundantly qualified to talk to today's topic. Over the past 20 years, he has directed a portfolio of federally funded research in health informatics. His research focuses on technology usage in medicine and tobacco cessation. He previously served as the inaugural chief of the Division of Health Informatics and Implementation Science within the Department of Population and Quantitative Health Sciences at the University of Massachusetts Medical School. He did that for 10 years. He also served as the director of the VA's Quality Enhancement Research Initiative for eHealth. The title of his talk today is Recent Advances in Learning Health Systems. I'm very excited to hear what it is he has to say. Please join me in welcoming Dr. Houston to today's installment of our iMpact seminar series. Dr. Houston, it's over to you.
Great, thanks. That's great. Okay, so I decided that I might talk about some recent advances. So learning health systems is certainly a nascent and growing area, so this is sort of drawing from some presentations that we've had for many years at the American Medical Informatics Association annual meeting, where a speaker sort of goes back and looks at the last year and does a sort of a brief review of different topics that are having like sort of growing voices in the field. And so this is sort of mirrored on that. And so what sorts of things are going on in the literature and at meetings. So it's basically a brief synoptic to review. It's not designed to be comprehensive, but designed to identify some key themes. And so I did the first, a PubMed search for what's been published in the last year. Also, some highlights from national meetings. What we often do is for meetings that a number of us attend, like the informatics meeting, the dissemination implementation meeting, and others, we send out a note to the folks we knew attend and say, what are the top 3 things you learned from the meeting? And so some of those I've incorporated here as well. So here's the main, 4 themes I think have really dominated much of the literature over the last year. And this is both in the Learning Health Systems journal itself, and then in academic medicine and other major journals. So we're still sort of talking about models of learning health systems. So like as the field starts to grow, these frameworks, models continue to expand. And then there's a very interesting discussion about tensions in learning health systems. So that one concept in learning health systems is the integration of clinical operations and research, and the research is integrated within the delivery of healthcare. and there are certainly some trade-offs and tensions around that. And a lot more I think that can be studied in that area. And then there's the concept of evaluation, right? So like if we have this vision that learning health systems is a thing, and it's going to add both to research and quality improvement, how do we evaluate it? And then this concept of like a multi-system national or international learning health systems, growing from individual learning healthcare delivery systems. So those are the four things I'm going to talk about. And so first, let's talk about models of learning health systems. So we published this work in the past year, the Academic Learning Health System, a framework for integrating multiple missions of academic medical centers. And so this builds off some prior work by Doug Easterling and colleagues that did a comprehensive synthesis of the literature to identify 5 core aspects of learning health systems. And essentially the literature is expansive, but all over the map. So like there's a number of inconsistencies with what they're describing as learning health systems. And but these 5 core were the ones that sort of bubbled up to the top, that are in brown in the center of the figure here. So building new knowledge, translating evidence into practice, engaging stakeholders, continuous quality improvement, and organizational learning, and clinical data analysis. And so for our work, we talked about, like, so how is a learning health system that integrates an academic core, a medical school of medicine, university, is it different at all? And it may not be, but what we identified was these 6 emphasis areas that expand upon the 5 core aspects, and also relate to the 3 traditional missions of an academic medical center: healthcare delivery, research, and education. So it's really not our intent in this to have this be the end all and be all of an academic learning health system, but the goal is sort of to start a conversation about is there a difference in emphasis, right, between the general learning health system and one specific to academic systems. So just talking about the 5 core features again. So engaging stakeholders, engagement of clinicians, patients, and other care partners, that would include community members, is a core aspect of learning health systems in the literature, but has certainly been underemphasized both in the literature and in reality. I think this is one area that we really need to focus on. And then building new knowledge and evidence, improving patient care and health outcomes. So as you're in the process of clinical care, can you create new knowledge? And then there's also the companion to that, translating evidence into practice, right? So identifying, critically assessing, and translating knowledge for improved care. And correlated to that is so the critically assessing, right, is an important part of it, and the prioritization. So one of the things we worked on here is recognize that we can't do everything at once. How do we select particular innovations, to implement and evaluate within our learning health system core? And so continuous quality improvement, organizational learning. So that is certainly one of the core pillars that's built learning health systems. And then final clinical data analysis is another key pillar. And so these are all sort of integrated together, right, and rely on each other. But as you can see, that within the literature, the learning health systems is definitely built on things that have existed for quite some time: implementation science, informatics, improvement sciences and CQI. The further emphasis on learning health systems is the better integration into clinical operations. So then, so beyond these 5 core features, then the model that was published last year talks about these 6 emphasis areas within academic learning health systems, right? So an academic learning health system capitalizes on embedded academic expertise in health system sciences. And then there's some particular areas there that we've talked about, including informatics, artificial intelligence, implementation science, organizational behavioral, biostatistics. And the idea is that these resources provide the ability to develop novel delivery strategies that are theoretically based, and then to create new knowledge. And so again, this is not to say that there aren't academic expertise in learning health systems that don't include a school of medicine or a large academic center. So there are learning health systems that are that don't include a large academic core. They have some of this academic expertise, but it may be particularly emphasized in academic learning health systems. And then we feel that academic learning health systems may also emphasize external knowledge dissemination, right? So that there's another article that was published a couple of years ago by Tom Foley, a colleague, talking about the integration of quality improvement and learning health systems. And one of the things that's overemphasized is the sort of the afferent and efferent loop to the quality cycle, right? And so how do things get in to the quality cycle? How do we pick the things that we're going to implement and roll in? And then how do we spread them, right? And so academic learning health systems may be well positioned to spread information to external partners and other systems. And then focusing on community partnerships for health equity. Academic medical centers provide care for a disproportionately large number of socially disadvantaged individuals, and they often have as part of their charter a social responsibility to advance social good and move beyond the goal of improving health care to improving health for all. So this is an interesting topic in the literature, and when we were publishing in academic medicine, several of the reviewers had some strong comments about this, recognizing that this is true, that we do have a mission to care for socially disadvantaged individuals and advance health equity, and also that we can't do everything by ourselves, right? So there are also there are important policies, payers, governmental agencies, community partners, and the other healthcare systems out there that need to be involved in this process. And there are a number of interesting articles, if you're interested, that I can send you, that talk about sort of this controversy of, so yes, that we should be emphasizing this area, but then again, we can't have it be expected that it's solely dependent on the academic system to do this. Then the other 3 are learning health systems integrated into education. Certainly, academic learning health systems are more about education, and so can we both integrate education about learning health systems into the educational process, but also use learning health principles to evaluate our educational programs and integrate trainees into the cycle of improvement that is the learning health system. So then building pipelines for learning health systems experts and clinicians that are fluent in learning health systems. Again, we have a really important role to play in building this pipeline. So we have a training program here that is connected with our Clinical Translational Science Award for training both junior faculty and postdoctoral scholars. And of course, there are also training programs that have been supported by the Agency for Healthcare Research Quality and PCORI to train new experts. And then the last emphasis area is that we often think about learning health systems as at the far right side of the translational spectrum, right? So the implementation science and beyond. But traditional, academic learning health systems really have the full pipeline from basic science on, and we can sort of take that work and move it along the pipeline. So anyway, I'm just emphasizing that as one example model. I also wanted to emphasize this model as well that is that's out there, published by Katie Trinkley at Colorado and Russ Glasgow, who's a national expert in implementation science, thinking about how D&I can contribute to the advancement of learning health systems, right? And so I'm not going to go into this model in detail, but I also think it's a really valuable one that's out there that thinks about the different levels of thinking about all these complex adaptive systems, and then how can we apply D&I science to contribute to learning health systems. So there are a growing number of models and frameworks out there, which is a common to a growing field. And then so the second, I'm going to sort of shift to talk about these tensions in learning health systems. So before the start of the seminar, Tim and I were talking about one of my roles is in integrating clinical operations and research, and every Friday, I meet with our as part of our clinical operations group in the university group practice here. And so the three core groups are ambulatory care, inpatient care, and interventional services. And then the fourth is what we call the Learning Health Systems Committee, or Academic Advantage, and that's me and my group. And so our job is to sit and understand what sorts of things are going on in the natural experiment of the clinical system, what new initiatives are happening, and how could they be enhanced with learning health systems expertise, and then facilitate connections between them and the investigators. So that's sort of we serve as a bridge, but there are also these tensions going on. And so what sorts of tensions are we talking about? So this is from an article published by Reed and Green in Learning Health Systems, Gathering Speed and Countering Tensions. And so we talk about a number of sort of aspects of these tensions, right? So one is, what's the purpose, right? So are we meeting the business objectives of the system? Are we trying to disseminate generalizable evidence, or is it somewhere in between? And how do you connect those two? Because sometimes they are not quite aligned, right? So and also there are multiple business objectives, right? So if you're more of a frame of fee for services, you're looking more efficiency. If you're looking at more value-based care, population health contracts, it's more aligned with what we often think about as quality and holistic care of patients, right? And so what's the purpose of the efforts, right? And what are the learning goals, really? Are we thinking about it more as a healthcare system goal, or as a health system that may more involve patients, families, communities? And then aligned with that is like, what is the agenda? Is it a pure research agenda, or is it a health system agenda? Are there community priorities? And then what's the approach, right? Is it operationally practical, sort of rapid cycling, or is it more methodologically pure? And what's the balance, right? So that these are continua, right? And so it's not necessarily true that you have to lean completely one side or the other, but the article I felt useful because it's voicing these tensions that anybody who's doing this kind of work sort of recognizes are there, but I hadn't heard them explicitly organized in this way. And so, yeah, so then what about the data, right? So are you going to do a lot of primary data collection, or are you going to use a bunch of, secondary data? And so I would say, like, are there ways we can, identify data that would be valuable to research and learning health systems, and also to the healthcare delivery system, and then collect it as a routine process of care, and then we can use it secondarily. So, like, certainly an example that is now being mandated is collection of social determinants of health, right? So there are a number of additional data elements that could evolve over time as things that are routinely collected in healthcare. That now we often have to do primary data collection for. And then what about the technologies? So oftentimes they're, within an electronic health record system, there are a number of important concerns, including creating lag in the system and information security issues that may limit innovation, right? So you're really looking at working within the zone of what is typical and doing marginal improvement, or doing sort of rapid disruption and connecting new things to the system. And then short-term projects versus ongoing, infrastructures. An infrastructure would be a clinical data warehouse, of course, would be an infrastructure. Another infrastructure some systems are now implementing is like what I would call a learning health system test kitchen, right? A small number of clinical units that have been identified and incentivized to kick the tires of new things, right? So that each project that comes along doesn't have to find new partners. So those are ongoing infrastructure. So where are you going to allocate your resources to, sort of short-term pilot projects or these ongoing infrastructures? And then thinking about, of course, the tension between the full research oversight, regulatory, and then the QI process, and then there is some work recently about the gray area in between, right? So anyway, the really interesting article, and I would predict that there'll probably be more discussions in the literature about these issues as we move forward, and what sorts of things can we do to address some of these tensions. Certainly, expanding our number of learning health scientists, learning health system scientists who are informed in these areas, and also informing our health system leadership, and also engaging with our research funders, right? Recognizing that there are less pragmatic approaches, and then there are pragmatic trials, and that there are things even beyond, on the edge of pragmatic trials that are really more rapid cycle, that also need funding support. There's a good bit more in the article that talks about some of the addressing some of these gaps. But what I think I'll probably do is that Stephanie's going to send out the slides, and I'll hold off on going into some of these details because they're in the slides in the paper, and move on to the next topic area so we have some time to chat. So evaluating the learning health system is the next sort of area that is sort of in the minds of people who are publishing articles in this area. So how are we going to assess and evaluate what we're doing, right? So it's been over 10 years now since the Institute of Medicine's landmark descriptions of learning health systems, and as we're rolling these out, we want to demonstrate what's the value both from an academic perspective and from a return on investment for clinical systems. And so it's really challenging because the field is so broad, right? And so you think about learning health systems is built upon these prior pillars, data sciences, improvement sciences, quality improvement of systems engineering, implementation science, and so it's so broad, right? And then each system that is growing towards a learning health system maybe focus on different attributes, right? So it may not be fair to evaluate each system in all the different potential aspects that were in the frameworks that we discussed, because they may not be focusing on each of those, components at the same time. And so what do we do about that? So there are other examples in the literature of this challenge, right? Evaluating a complex multi-attribute change to the healthcare delivery system with different, strategies that may be implemented in different ways at different places. And one example is patient-centered medical home, right? So in concept, patient-centered medical home is really important, and it was driven by prior literature, but a number of approaches to evaluating comprehensively patient-centered medical home did not demonstrate any change. And one reason was because, it was not, the evaluation wasn't adapted to the changes that were emphasized at each local healthcare delivery system. So, I mean, one approach from the informatics literature is this idea of a maturity model, right? And so you may be able to mature in different ways, right? And so it's been developed in the information literature, systems literature. There are maturity models for research data warehouses, for example, and define a state of progression towards, an ideal state. And the idea is that higher levels of performance are achieved with higher maturity levels. And then, however, the specific definition of maturity often depends on the context, so that it sort of can be adapted. So actually this one is a sort of a deep dive. It's from a Google search, and also it was highlighted at the American Medical Informatics Association meeting. This is from a dissertation by a scholar at the University of Michigan who works with their Learning Health Systems group, and talks about a maturity grid for learning health systems with these 6 domains, talking about how the systems of leadership have been engaged in the concept of learning health systems, where the governance and management components, quality improvement components, community building and engagement, data and analytics, and sort of the research maturity within the system. And then each of those domains has been proposed to have 7 components that can be evaluated with a rating scale, as you can see here, right? So this is a very interesting start to a maturity grid. I mean, one challenge, of course, with these maturity models is that there's a lot of self-report in it, right? So it's the individual system is evaluating the maturity of their own system along these 7 components and reporting the data. It's a little harder to have a independent external evaluation because a lot of these assessments are somewhat subjective and based on interviews and or self-reporting. But you could see how you could develop a sort of a summary of which different directions is the system growing in, right? So it may not be all of these 6 components of at once. And I expect that we will probably see more of these sort of maturity models come out, and this one will likely be published in the near future in the peer-reviewed literature. but I think it's sort of like this part of the talk. So I wanted to bring up just to primarily to emphasize the challenge with evaluating growth of the learning health system, because it is so complicated, and every system may be focusing on a different aspect of the growth of learning health systems. So data, or the clinical operations research integration, or community and stakeholder engagement, and that's okay. You don't have to do it all at once, but how do you adapt the evaluation to the activities that are actually going on? So anyway, what I think I'll do, it's okay, is maybe just pause for a moment there and see if anybody has any question about these two topics before I go on. So I'm going to just stop my share for just a moment.
If people want to put questions in the chat or raise your hand and we can unmute you. Tim has a question.
Yeah, go ahead.
Yeah, thanks, Tom. This is Tim. So I've been reading a bit about the maturity models, and they really are kind of like almost like process measures. I mean, in terms of evaluation, how do you measure impact? How does that maturity level translate into impact? Because one of the questions that's been asked of LHS is, what's the value proposition?
Right.
And to what audience? The C-suite probably wants to see different metrics than the tenure committee. And so how do you kind of go from a maturity model from an organizational standpoint to looking at impact and outcomes, and what sort of outcomes are kind of unique to LHS, this LHS world, outside
Right.
of grants, publications, and those sorts of things.
Yeah, right. Yeah. So I think that the future is not set on that, right? I mean, I think that there are certainly some of these analogies, like we talked about, the patient-centered medical home, right? And like the challenges of measuring sort of like outcomes in that space. And then another example that, these are examples of failures that we should learn from and do a better job, right? Is the work through NCATS and the Clinical and Translational Sciences Awards to harmonize evaluation and to create standard outcome metrics, right? And then there's the translational sciences impact model out of WashU and some other things now, but again, it's sort of like how do you take, it's almost like it, so you have to have a targeted or an adaptable evaluation of what activities are going on, right? And then how do they line up with potential outcomes, right? And so it almost seems like that you have to some model where you identify the targeted processes that you're going to improve with a maturity model, and then state up front your expected outcomes, right? And then you can monitor the observed, and you can do a sort of observed over expected for each learning health system unit of interest, right? But I think if you it's so broad that if you try to apply the exact same framework to all systems, then I would probably predict that you're not going to find a whole lot, because it's being rolled out in such a different way and in such different systems. But I do think that if systems can have that conversation up front about what are we doing with this, right? And create the sort of the expected outcomes, then you're better to move forward to measure it. But thanks for the question. So I think I'll just go ahead and go on, and then we can come back if there are other questions about the evaluation. It's certainly for all of our scholars, it's a rich area of study and evaluation, right? With really important and a lot of challenges also. So the last component area I wanted to emphasize is this sort of idea of how broad is the learning health system, right? Are we focusing in on individual hospital systems, or do we expand to multi-system national integrations of learning health systems? Certainly that is easier to do if you have a national healthcare delivery system and some national approach to evaluation. And some of the earliest literature is coming from places that have that, which we in the U.S. do not. But this is an article by Collard and Grimbaugh in Academic Medicine last year. It's interesting that a number of these articles that I'm highlighting are coming from the Academic Medicine Journal and not from the Learning Health Systems Journal itself. But certainly it seems like people are choosing to publish some of this in academic medicine. So the idea is that how can we focus on these multiple levels, right? So the local level, making sure that the health system leadership is champion the learning health system. And so incentives and opportunities are there, investing in the infrastructure, right? I think that, that brings me back to the original sort of statement in the Institute of Medicine. It had these four characteristics of incentives, culture, data and science, right? And so we're working really hard on the data and science part, right? But what are the incentives and the culture, which building infrastructure is a component of culture, right? But changing and evaluating those is an important growth area of learning health systems as well. So the regional, engaging with community leaders, leveraging regional partnerships with stakeholders, either that it would be including governmental partnership or other stakeholders, advocating for regional policymakers to pilot initiatives. And then national, creating these larger learning health care system consortia of systems that coordinate local and regional efforts, and how do we fund these and evaluate them through federal priorities, and then how do we scale things, so things that are found to be effective, how do we incentivize adoption of them in the larger national learning healthcare system? So those are some of the thoughts that come out in this article. I think it's really sort of interesting. I think we're a ways from that, right? And so it's really hard to get everything coordinated. There are some initiatives. So PCORI has launched this health systems implementation initiative, or HSII. There are like 40 systems that have been funded through the a $500,000 capacity building grant. And then the idea is that now that these 40 different healthcare systems are in the club, they can apply for additional PCORI funding to do evaluations and implementation of things that have been proven to be effective in the larger community. However, at this point, it's an incomplete, start, because they're not emphasizing multi-system collaborations, except for that they built this, club of 40 systems. But each system is applying for its own funding to do the implementation of whatever the target is that PCORI is rolling out. Not trying to roll it out, one thing in 10 different sites, for example. And then this is another article from British Columbia talking about expanding learning health systems beyond academic health centers. they had created a post-COVID interdisciplinary clinical care network, and a large number of patients are assessed through telehealth. Were assessed through telehealth appointments, and there were data collection infrastructures that they embedded within the system, so that they, when in this care network, they can not only be engaged in care but engaged in research. And they're somewhat similar initiatives on a state level here in the U.S. One example is the Medical University of South Carolina has a virtual care center of excellence supported both by the state and by HRSA, and they're reaching out to other areas of the state. They're not in the Charleston catchment area, but they have individuals have very low access to primary care, and doing distance, nearly 100% distance care for those patients, getting them into telehealth across the state. Anyway, I did sort of a case report of a model that was used in British Columbia. And then there's an international perspective piece that was also published for the Association of Academic Health Centers. And they listed these sort of key considerations for building an international learning health system. And as you see, a number of them line up very well with the models of learning health systems that we started with at the beginning of the talk, right? So how do we engage all these different key considerations and get learning health systems at the higher level than what we're thinking about now as individual systems? And so there's also this was a protocol paper, so implementation model for a national learning health system, that was published in the British Medical Journal. So this is just a concept analysis and systematic review protocol that hopefully will be have a further publication with some actual data soon. And then I just want to follow up with like some of the things I mentioned is that we ask folks at the different who attend the different conferences to also send us sort of like most interesting things that are talked about. And so one is at the D&I meeting, there was a very good talk this year by the group from Cambridge, and it's called the This Institute for improving quality in science, and you can Google them, and the link is there. They have some really interesting reports that are very much aligned with our concept of learning health systems. So that was a very broad review, and I think I sort of go back to the four themes here of what sorts of things are going on now. Expanding models of learning health systems, these sort of tensions between research and operations, the need to evaluate it, but the challenge of it, and then also the future-centric approach of how do we do multi-system national learning health systems. Anyway, I will stop there, and I really appreciate the opportunity to come and chat with you all, and happy to talk about whatever aspects are interesting to the group.
Great. Well, we already have one question. Gretchen asked, she has a question, or they have a question about infrastructure needs and recommendations for building that, particularly with regard to ethics, IRB knowledge of LHS type studies. How do you build capacity for that?
Yeah, so let me see here. Infrastructure needs for building about. So Gretchen, you mind saying a little bit more about that question? Like, what is that? that we're referring to.
Gretchen, if you could elaborate in the chat, perhaps, or if you want to be unmuted, let me know. Oh, I will unmute.
Mhm.
Okay.
Hi there. Tom, thanks for your presentation. It's really interesting.
Mhm.
Yeah, so I'm interested in your thoughts around, you talked a lot about technology development and that type of thing, but I'm curious about working within a healthcare system whose IRB has historically been very biomedically based,
Mhm. Mhm.
perhaps doesn't have a lot of experience with implementation science and learning health systems, and just kind of any thoughts that you have around building capacity for people having expertise who can review studies and
Sure.
provide input.
Right. Yeah, yeah. So that's a great point, and it's true in a number of systems. And so, I think it's an interesting, conversation to have with both, research leadership and clinical operations leaders at the same time, right? So I would involve a number of different stakeholder groups, in that, right? So the idea is that the IRB is not doing anything, incorrectly. It just maybe the frame, may be a bit challenging, and the folks that are sort of reviewing protocols, right? So, different institutions have a different, perspective on it, but um, one would be, to create a different, pathway for evaluating smaller, mostly QI or data only studies. So early sort of low risk projects, because so if they're thrown in with drug trials or other high risk things, the emphasis becomes unbalanced, right? And then so that to me, I think that's a little redundant, and I think it's probably not the best approach to go. To create a whole different, review process or a separate system, but you could do something like, like flags within the IRB submission, process, right? That identifies what the study is trying to do, and how should it be addressed, right? So if it's one, data only, and two, it clearly has letters of support up front from the clinical operations, it might go down a slightly different track. Is that helpful in response to your question?
Yeah, thank you.
Yeah. So a number of different things. So we're on a conversation of a number of funded R01s a week ago that a new challenge had arisen. And so this is a community-based intervention that is broader even than the catchment area of the clinical system and goes out into rural areas. Not all of those areas recognize or are even potentially fans of the university clinical system, because they are not providing any care to the patients in that area. And then the clinical system insisted on having branding review all of their materials, and I'll brand them with the academic health system that will not be identified on this call, mottos and everything, because that's what they do. But then it was off-putting to the people in these very rural areas that the investigators were trying to work with. So that's a small example, but another thing that, so these common branding things, we experienced a little bit of them also and have to negotiate through them. But there are all kinds of things that you have to address when you're that are not true for basic science or even for your regular pragmatic trials.
Great, thank you. We have time for one more question. Rubina asks or states that one challenge she faces as an academic / LHS scholar is the limited interest from IT non-academic personnel to continue their support with the dissemination phase with the ongoing duties. I think there is a need to incentivize non-academics to publish LHS work and is indeed a fair ask.
Right. Yeah. So I agree with that, Stephanie. So what was it the beginning part of that? I mean, was it IT or?
Yes, so limited interest from IT or non-academic.
Yeah, agreed. Yeah. So I mean, what I often see is that, I mean, that's part of the also the challenges, right? Is that they are likely being pulled in so many new directions, right? That they're on to the next big task, way before what you're doing now is supported the evaluation is completed, right? So there's I certainly don't have a perfect solution to that, except that, like if we did have an approach where our research infrastructure, the dean's office and other senior research leadership were providing some longitudinal support, for building and integrating with IT, and that would help. Oftentimes the core IT is supported by different color dollars than our research, and that can be a problem of integrating across the two systems. But yeah, so it's a very common problem that you can get IT help, at one point in the project, and you can get a lot of yeses, but then they get pulled into some major next big thing, and then they're not going to be with you for the whole time. I wish I had a better solution to that one.
All right. Rubina says maybe a criterion for their annual review. But yes.
Right. Or the alternative is to have the clinical system stop identifying next top priorities, or it's like let's set a strategic plan and then revisit it every 6 months so that we can change the 5-year strategic plan every 6 months. That's unfortunately the norm.
Yes. All right, with that, we are at time. I want to thank everyone for joining us today, and thank you particularly, Dr. Houston, for taking the time to present. And in closing, please join us for our next seminar on April 2nd at noon. And this concludes our presentation. See you next time.
Thanks, Tom.
Thanks. Yeah.